So welcome back to the second part of our podcast episode on surgical training. For those of you who haven't had the chance yet to listen to the first part where we were joined by 3 excellent surgical trainers, please do have a listen. It's available to listen through multiple platforms, including Spotify. Just to reintroduce myself, I'm Ravina. I'm a current registrar in North Thames, and I'm joined today by Tanya.
My name's Tanya, one of the new academic clinical fellows in ENT in Birmingham. I'm very happy to be here for the second part of our podcast, in which we'll talk to 3 very excellent trainees.
I'm going to hand over to them to introduce themselves.
Hello everyone, thanks very much for inviting me, Tanya and Ravina. My name's Talisa Ross. I'm an ENT ST3 registrar in North Thames and also an academic clinical fellow. Thanks.
I'm Stefan Lindon. I am currently the educational fellow at Salford Royal Foundation Trust, and I've recently obtained my ST3 number in ENT. I'll be starting in Edinburgh in Scotland in August.
Hi, my name's Sam Dewhurst. I'm an ST trainee in the east of England. I currently work at Peterborough City Hospital.
Great. So I'm just going to get started because we've got a lot to talk about. I want to firstly talk about your training experiences during COVID. As we know and read on social media, it's quite easy to focus on the negative aspects of training during COVID and how we were all adversely affected. But I know that some of us have had quite positive experiences too, and I think it would be quite nice to touch on that. So I'm going to start with Talisa because I know that you had a especially unique experience during your core training.
Yeah, I did. I was a core surgical trainee when the pandemic struck. And as is the case in a lot of places around the country, intensive care can be part of the compulsory core surgical training rotations. So I was brand new, green to intensive care and got about a month in when COVID struck. And I remember, all the preparations that were underway about this mysterious virus coming over from China and would it ever affect us and things like this, whilst I was still absolutely terrified as the token surgical trainee on ITU trying to work out how on earth the ventilator worked. Fast forward another month and I was obviously in the midst of everything that was going on. I was working at Charing Cross Hospital at the time and I was very grateful that the team there really took everyone working within the department, both those who were there already but also people who were redeployed, under their wing. And of course, there was a large element of service provision during my time there, but also there was an awful lot of training and teaching. I ended up, rather than spending 4 months on the units as part of my mandatory rotation, being extended for 8 months as I wasn't allowed to rotate. That was the time where all the rotations were postponed. So I ended up doing 8 months of my first year of core training in intensive care. And then I got redeployed in my CT2 year. So I did another 2 months. So of my 2 years of core surgical training, I ended up doing 10 months on ITU. In retrospect and going forward, I am actually quite grateful for the way that it panned out. I was in a very supportive department when I started learning the ropes and things. And actually, as time went on, I found that I was quite enjoying it. And I think to somebody who is interested in ENT or already looking into a career in the field, it's a really useful specialty to not just get a little flavour for, but a bit more of an in-depth experience. And I'd say this year, particularly my ST3 job has been in laryngology. I think it's given me a deeper understanding of the sort of airway considerations that I definitely wouldn't have had I not had all that time on intensive care.
Great. And I think you're being modest because by the end of your time there, you were holding the ITU reg bleed, I heard.
I was. It was a strange time, pandemic times only, but again, really, really useful. And I think it's made me a much more rounded doctor.
Sam?
Yeah, I was already pretty well established in the training program when COVID kicked off. So it was during my ST6 year. I was working in Peterborough at the time. I was quite lucky in some ways in that I avoided being redeployed. And also, much as this is somewhat of a double-edged sword, my other 2 specialty training colleagues were either indisposed or shielding. So I was left as the only trainee middle grade in the department, which certainly had its plus sides in that the department afforded me some flexibility to attend a lot of lists and keep my numbers up, but it also meant quite a lot of additional responsibility and quite a lot of additional duties. I think the big impact for me as a more senior trainee that COVID's had is it's definitely affected our breadth of specialty exposure. And I think certainly anecdotally speaking to other colleagues as well, there's been a heavy skew towards the head and neck side of things, as that's the service that's been least curtailed as a consequence of the pandemic over the last couple of years.
Now that seems, the start of the pandemic seems it was so long ago, but for me personally, during that time, I was still in ENT, but I was transitioning into different rotation. So I was focusing more on trying to accomplish as much as I could so that I could make myself more competitive for applications. So when it had initially broke out, I was still on an ENT middle grade type of rota, and everything came to a halt. There was no more rhinology. That was off the question. Laryngology stopped. Otology, that stopped as well. And as Sam was saying, head and neck was prioritized because there were cancer patients that were still coming on. Our department itself switched from different trainees getting lists to just going on trying to adapt to the new atmosphere. We started to try to do telephone clinics. Lists were prioritized for more senior trainees in terms of head and neck experience, and other trainees had to basically divide the list. So I know they couldn't really get as much operating time as they needed. I had to move from ENT into pediatric surgery, as that was a allied specialty. So I got some points from my application for that. That was, again, very odd. It was an odd time where all non-elective surgeries stopped, and their trainees didn't really get to operate as much, and the patients that were getting operations were more complex, so mostly consultants were operating around that time. And then from there I went into cardiothoracics, and at MRI it was a heart center, so we're doing a lot of CABGs. And again, their list had slowed down from doing 3 CABGs a day on one single list to just getting 1 done because of the isolation periods. So again, my role as a doctor in a surgical field was basically curtailed to just managing the wards. We didn't get much time in theaters. And if you did get time in theaters, again, senior trainees were mostly prioritized.
And how do you feel that that's had an impact sort of a bit more long lasting since then?
I think the main impact for me is it has definitely informed my choice of subspecialty interest. I was always on the fence really between otology and head and neck, and my exposure over the last couple of years as a senior trainee has been very much weighted towards the head and neck side of things, and that's the direction that I've gone in now. So I'm now due to start a consultant job in thyroid and laryngology. Yeah, that's probably been the biggest impact for me.
Amazing. Congratulations.
Congratulations, yeah.
Mm-hmm. And Talisa?
From my personal perspective, I think I was quite lucky when I was not on ITU. I had quite solid ENT jobs, so I still had reasonable numbers compared to colleagues of the sort of pre-pandemic era. So I think I was able to catch up, but I think I was going for the record at the highest number of central line insertions recorded on ISCP. But I think overall, with the transition this year to becoming a registrar, the consultants I've worked with have been very understanding of the context of my core training. And I think they've been very good at talking me through. And actually, they've said to me there's very minimal expectation in terms of the elective side of things anyway. So that was reassuring, particularly at the start in terms of where I was on the learning curve because of all my time out of surgery during the pandemic. And so I think overall, I hope we've managed to catch up.
Thank you, Talisa. So let's move on to talk about national selection. As we all know, national selection is a big hurdle that most trainees have to go through, and also a very widely spoken about topic among trainees. We've spoken to the trainers about their perspectives, but obviously we would like to find out your experience as trainees. So what do you think about the structure of the portfolio changes?
So I didn't apply 2 years ago. So I came in the following year when there had been a bit of time to iron out the creases, I guess, following the emergency implementation of the new selection process. I'd obviously heard from friends who had applied the year before about what had happened. So I think with the group I applied with, there was quite a lot of anxiety about what would be included, because it was basically what we thought would be deemed important enough to remain in the selection process. And obviously that was in the context of allowing for some small dynamic changes as a process was reviewed to work out the best newer way of selecting potential registrars. certain things that I think was a shame to have come out from the old system. I was actually talking about this with a doctor on a taster week in theatre this morning, that the tonsil tie station has obviously gone because that is no longer possible to analyse via a Microsoft Teams interview. And it seems a strange thing to recruit for a surgical specialty without analysing any sort of practical skill. But I believe for now, sticking with the virtual format, there needs to be other ways that come in. For my year, the biggest change was the introduction of the communications station. And again, nobody knew what that would consist of, nor did we know what it was being marked against. So I had to speak to quite a few colleagues, both current registrars and consultants, about what we felt may come up. But actually only having looked at my feedback after the event was it apparent what it was actually looking at. So I believe it was just assessing general communication skills. But I think from that perspective, it was one of the more stressful parts of the process because it was the area that you could prepare for the least. The clinical side, I think, stayed pretty consistent, and there was, in a way, less worry, although you'd think that would be more difficult because you could predict the sort of material that might come up.
Yeah. Thank you. Stefan, what do you think?
So I'm an international medical graduate. I'm a Barbadian originally. For international medical graduates, always a bit more challenging because a bit more hurdles that we have to jump through. So when they came out with the different assessments, they increased the time in ENT because they found that trainees would not be able to accomplish their operations given their time at being allocated. And that helped me a little bit. So I was originally going to get 0 on that assessment, but because they extended the time period, I was able to at least gain 15 points. So that helped me. And I think last year, was the selection for 2021. They moved the interview kind of change where it was all virtual. Again, it was very new and novel to everyone. And unfortunately, the communication station I found to be very nuanced, and I didn't know what to expect with that. I think they wanted you to give a 5-minute oral presentation about the qualities of a good ENT surgeon.
Actually, Ms. McDermott did acknowledge that, and they said that communication station in 2021 wasn't as discriminatory as they thought it would have been. And actually they responded fairly quickly, and they changed it this year to a research type scenario where they had to analyze a paper because they felt that would be a better discriminator between candidates. So they definitely took that feedback on board. But I think a lot of us felt that way with that presentation as to how do we make ourselves stand out, because everyone's going to say fairly similar things. And I think, they definitely acknowledged that earlier in the podcast.
I think as people interested in ENT, we're quite almost self-selecting in a way, that people tend to be fairly good communicators and quite sort of good talkers, relaxed personalities, who I imagine would come across pretty well in a scenario like we had in 2021. So that doesn't surprise me that it didn't act as a particularly good communicator. And I think the paper that was given out this year is a much more objective way of marking people to compare and discriminate.
I'm just going to bring it back to the self-assessment score. We asked the same question to the panel of trainers the other day. Do you know the self-assessment score now include achievements from medical school? Do you think that's a fair thing to do? Because as we might know, ENT is not its exposure in medical school isn't that great. So people decide to do ENT quite later on. Sure. If you decide to do ENT earlier, that's good for you. If you haven't, then you might have missed the point. So do you think that's fair or not?
I think you've really hit the nail on the head, Tanya. I think if you decide early, it's a real advantage. I personally was fortunate, and I was at Birmingham Medical School. We had quite a lot of ENT exposure as part of our compulsory rotation 3 specialties. We all did 2 weeks, plus I did extra. But for those who haven't decided, even well into core training, I think it's very difficult to claw back those extra points, particularly, as we've already mentioned, that it could be the difference between 1 or 2 points between getting a job and not getting a job.
So in terms of the sort of relative merits of the self-assessment and other things, and whether we feel that people at medical school or achievements at medical school should be counted, my personal view on this matter is I think a better discriminator of a successful trainee as a registrar is what they can do on top of a full-time job, not what they can do while they're studying. And I'm personally pro discounting medical school achievements for that reason. I think also my view, I will admit, is potentially prejudiced in that I was someone who decided pretty late. I decided halfway through CT2 that I wanted to do ENT. But yeah, I think the other thing with the self-assessment side of things is, and I think this is cross specialty and applies to core training as well. Looking back at things coming towards the end of training, I think it's interesting the way that points are allocated, in that the number of points for the amount of work does not correspond particularly well.
Can you clarify what you mean, Sam?
A great example would be our logbook requirements in ENT for ST3, which differ quite significantly. And I think the thing about ENT ST3 national selection, when you compare it with other specialties, I don't know if you guys have seen, there's a very nice article in the RCS that was published a couple of years ago on this. We both weight portfolio most highly by a considerable margin of all surgical specialties, and also have the lowest logbook requirements of any surgical specialty. So my personal feeling is to have done 1 tonsillectomy trainer scrubbed, 1 grommet trainer scrubbed, 1 direct laryngoscopy trainer scrubbed, and get the same number of points as having published 4 first author papers seems to me a little disparate in terms of its ability to select between candidates.
Yep. Stefan?
I agree with Sam. It's very odd as compared to other surgical specialties. When you look back at the history, it was felt as though the system wanted to basically move those registrars that were a bit more older and were hanging about in the system. But then you have numerous doctors who come in from different countries, like international medical graduates like myself, who look at the portfolio and say, okay, that's fine. I'm going to get 0 points for that. But okay, let me see if I can do a research degree, publish some papers, and see if I can make up the points in that way. It never equates. So when I came here, I wanted to boost my portfolio even more. So I did a master's degree, and that was worth 4 points. And when you look at doing another one in terms of doing a PhD, that's another 4 points. You get back 8 points. Even if you publish everything, you will never muster as much points as someone who just spent enough time in ENT. And Talisa was saying that every point counts. I'm not saying that you want to put, I get it in terms of you want new trainees and old trainees to be on the same bar, but it's very disproportionate.
Yeah, that's a very interesting point. We'll come back to that. Ravina.
Yeah. I just wanted to say, I think one area where perhaps improvements could be made is that there are discrepancies between deaneries. So, for example, in my core training, I did 6 months of orthopedics and 6 months of general. So I automatically had 3 less points than someone who had 2 allied specialties, even though my job was ENT themed. So that didn't make any sense to me. And I actually raised it, I think. And then my job the following year became 6 months max fac, 6 months general. And I think that's just being behind for no real reason.
Yeah. Go on, Sam.
So I think in relation to the time served question, I think there's a couple of things to consider. So I think on the one hand, it's really important to think about this from a sort of capital investment perspective and also from a workforce planning perspective. Really, if you're designing a training program, you want everyone within that training program to get the maximum benefit from the training program. And I think once you're getting to that point where the cutoff now is, from what I understand, 39 months and 7 days on last year's portfolio self-assessment, once you're getting to the point where you've done 4 or 5 years of ENT, you can very realistically argue that 6 years of higher surgical training is perhaps not necessarily the best investment from a deanery and training perspective for someone who already has that level of experience. The other side of that is the cutoff is extremely aggressive. And it does mean, and I had several colleagues who've been in this situation who are fundamentally excluded from application on the basis of having had ENT experience. And I don't think that's particularly fair because, like you said, to offset that potential 20 points, that's all of the papers, all of the audit requirement and a higher degree's worth of points. And if you look at the spread of portfolio points between appointable and the highest ranking candidates, the spread really isn't much more than 20 points.
Yeah. I guess the reason they do that is to give core surgical trainees the ability to progress immediately. I think that's probably why, because there's a lot of criticism about core surgical training and a lot of people who finish it and there's nowhere for them to go. So I think that's perhaps the flip side of why they limit the time.
Exactly. And there is a very strong drive across training now to make people's career path more predictable over time. It would be very convenient for the GMC and for the Royal Colleges and everything else for everyone to have as streamlined as possible a route through training. That makes it easier to plan what jobs we're going to need at the end, how many consultants we're going to need versus how many core trainees we're going to appoint.
Yeah, we'll definitely come back to the core surgical training aspect. And I just want to acknowledge the fact that it's not just for workforce planning, maybe for just people alive in general. When it comes to training, if they know where they're going, what they're going to do, which region it might help, that's another perspective. Talisa.
I was just going to come back to what Ravina was saying about jobs in allied specialties. I think there's very different levels of how useful jobs in allied specialties can be. And I certainly think exposure to the relevant ones are very useful. And there are arguably different things that you can get out of each of the specialties that are listed on the portfolio marking scheme. I think there's very different experiences that individual trainees have of each specialty. For example, there are certain specialties, without naming any in particular, that are pretty notorious for confining trainees to being on the ward and being on call all the time, stuck in A&E, and not getting that much operative exposure, when actually the justification would seem that the specialty is useful to a prospective ENT surgeon for their operative skills that could then transfer across, say, for example, in plastic surgery, where learning to do a microvascular anastomosis might be useful, or a management of wound closure, for example. Whereas if a trainee is stuck in a service provision role, fine, it might get them the points for the purposes of national selection. But is that more useful than them spending additional time in ENT? I'm not sure. I think it's very person dependent and location dependent as well.
Yeah, totally. So just to wrap up this area of the 3 process, going back to ST3 interview, the changes this year were announced quite last minute. What do you guys think? Do you think that was fair that trainees only had 2 weeks in advance notice, or should it have been way more in advance?
I think the warning period that they had was a pretty adequate amount of time to prepare, to be honest. So I went through the ACF interview process at the same time, which similarly presents the interviewing candidates with a research paper that you have to comb through and critique. And from memory, I think I also had about a week to look at that. So granted, for that process, I had a bit of time to go through some of the statistical things that I wanted to brush up on. But actually, the real higher level top scoring analysis that I hopefully got into my actual interview came in the last week once I'd seen the specific paper. So I think with the ST3 change this year to the new station, the time that the candidates were delivered gave them an opportunity again to speak to colleagues for some tips, to go through the paper themselves, to look up any areas that were also relevant to broaden the discussion, and then to look at some of the results and discussion sections of the paper to give their view on the quality and methodology and all of this sort of thing. I'm not sure that giving somebody a month to look at a research paper is going to add that much, because either you're able to critique it well or you're not. And I think it would be quite clear those who have got that ability within that sort of time scale to be able to come forward on the day and present what they want to.
Yeah, I think it's really difficult. I think on the one hand, I don't particularly have an objection to things being last minute. And actually, I personally feel that there should be some element of an interview that should be kept essentially unbeknownst to the applicants until the day. The reason I say this is I think that one of the most core things that we should select for, and that we don't often select well for using the current process of national selection, is adaptability and dynamic problem solving. And I think it's actually quite good to see how people respond to a novel challenge if you're discriminating between candidates. The other side of that is that if you're essentially putting people's futures at stake, that people have faith in the system. And if you come across as disorganized or shambolic in any way, it's very easy to leave the candidates feeling very embittered towards the system as a whole and, well, throwing the baby out with the bathwater. And ultimately, in the worst situations, potentially leaving the specialty to go elsewhere to pastures that they perceive to be greener.
Yeah. So if we go on to core surgical training, I think I've been touched on a few times already. So as we know, core surgical training is getting highly competitive year on year, really. But unfortunately, there's not enough ST3 numbers. And so
basically, this is leading to a last try phenomenon, basically. On top of that, there's a lot of substandard training reviews of core surgical training. I've seen this myself online as well as speaking with colleagues offline. I know Ravina has relatively good experience in core surgical training as well, but without challenges and struggles. What I'm trying to get at is, what do you guys think is the point of core surgical training? Just frankly put it, if you don't actually have an ST3 number at the end and the training is not that great.
The question about core surgical training and different points of application and other things, I think first kind of raises the question of what point is it most humane in someone's medical career to say, look, this isn't for you at the end of the day. I think the problem we have with core surgical training, however, is it's changed, I think, potentially from what it was, which was, I think, fundamentally once upon a time, a tool to determine whether you felt you were definitively surgically inclined and to explore and find a specialty where you fit best with a view to progressing onwards with your career, to a point where it no longer does that, I think, on the basis of how competitive selection has become and how it selects candidates. So you need to be pretty diehard committed from early on. I'm not hugely pro run-through training, but essentially I think the current situation leads to a sort of run-through by proxy type situation, in that you're selecting people only who would be opting towards that run-through direction anyway, and that most people are fairly dead set on their career at the point at which they're applying for CT1, but then forcing them through another hoop to jump through and another funnel to filter off quite a large chunk of them at the end of core training, which I think, does leave people pretty disillusioned. And I know a lot of people who've had a negative experience of core training for sure.
Yeah.
Not to say that some people haven't had a very positive experience.
Yeah. So yeah, what do you think, Talisa?
I'm not sure if this is slightly diverging from the question itself, but just adding to what Sam has said, my feeling is at the end of core training, the process of reapplying to go in at ST3 entry is actually a very useful preparation experience for life as a registrar. I'm not sure about the portfolio and the communication station or the research station in its latest format, but certainly from the clinical perspective, there's a lot of ground that I covered with friends of mine who I was preparing with that I felt in retrospect really got me ready for some of the scenarios that I have now encountered during my own calls. And I think had I not gone through the process of that following core training, I'm sure it would have been fine and I'd have sought advice as appropriate from senior colleagues that I've been on call with. But I think I've had that extra level of preparation by forcing me to consider some of these things that perhaps I may not have thought about had I not gone through that extra layer of ST3 recruitment.
Yeah. Ravina?
I agree with Talisa. I think we talk about it often, don't we, that going through that interview process, we learned so much for actual on-calls that we do now. And that was hugely useful. But further to that, my thoughts on core surgical training are that it's quite variable from region to region, from hospital to hospital in the way that it's delivered. And I think you can either have a very good time or actually quite the opposite. And I understand that with any training program, there have to be benchmarks. In the case of core surgical training, it's MRCS or exams, number of WBAs. And I was fortunate that I passed all of those in good time and achieved those things. But I remember feeling that actually I don't think I'm very well prepared to be a registrar. But because you only have to do one tonsil, one grommet, one adenoid, that really the path to success, I think, is actually to park all of that to one side and concentrate on the other tick boxes. But the consequence of that, I think, is that we're having, Talisa and I ST3s are having ST3s who perhaps don't have the experience of ST3s 10 years ago, which means that ST5, 6s, everything basically backs up. I remember speaking to one of my bosses who said he'd done 100 tonsils before he started ST3. I don't know how you can do that in the current system. When I was a core trainee, my ST3s needed to do them, which is completely fair. And so everything is just,
it's got a knock-on
it has a massive knock-on effect. And perhaps, I don't know, Sam can probably comment on that, being at the other end of registrar training than us, the impact that has.
Yeah, so I think it's hugely polarized. I think if we go back to when I was about to start my ST3 number, when we ran the first Northwest ENT boot camp, we found some really interesting information relating to people's capability at ST3, in that there was a sort of theatre management simulation scenario that we ran, which was essentially about taking ownership over a busy theatre environment. You come in with a case on the table, and the case was supposed to be a grommet and your boss had to run away. And the thing that very few of the consultants expected, and what we found was that a significant proportion of new ST3s, and this is even 6 years ago, did not feel confident cracking on and doing a grommet with their boss not in theatre, which was, I think, quite a shock to the consultants. And so going back even further, I think people didn't necessarily have huge amounts of operative experience. And I think it was very polarised. I was very lucky in that I did a year after core training because I needed 6 months of ENT in my core training. And by the time of national selection, I think I'd done, probably 70 or 80 tonsils. But as I say, that's not reflective of everyone's experience. And there were people at the time, even when I applied, who still certainly weren't very confident with the elective stuff and intentionally prioritised the portfolio stuff, which I have to say did not particularly, I'll be honest.
Yeah. So if you were to redesign core surgical training, how would we make this better for ENT's perspective?
I'd say that there needs to be more of a focus on becoming a day one safe registrar. Thinking back to when I was in the sort of analogous position at the end of medical school, once I'd done my finals, there was that sort of preparation to start working in a hospital environment. And everyone was there thinking, okay, I don't need to learn this stuff now to pass my exams and get through finals. I need to learn this stuff that's going to be clinically relevant today to be a safe F1 doctor. And I think the same thing applies to the national selection process. There needs to be, ideally, it's difficult to assess, but a slightly better way of evaluating what people are going to be like coming in as a day one registrar, both electively and in the on-call setting. And perhaps there needs to be a slightly finer tuned metric to evaluate that. I think that's partially covered by the existing clinical scenarios that are held within the interview format at the moment. I think me saying about what I would do versus actually doing it is a very different concept.
Yeah.
I don't know in terms of specifics how that could be better evaluated, but I think overall that maybe should be the focus.
So do you think ARCB requirement for core training should go up, or the self-assessment again should include more of what we're trying to achieve?
I think core training is always going to struggle in this regard. And I think ST3 interview has become sort of proxy for this, because the issue with core training is that the outcomes that you're trying to measure have to be generic across all surgical specialties on the basis of the fact that you have a large number of people doing a large number of different jobs, which have varying levels of responsibility and expectations for clinical and operative competency as an ST3. I think it comes into that same question again about to what extent does ENT national selection at ST3 determine whether you're going to be a good day one registrar? And I think the question that we really don't have a very good answer to is, what does the average consultant expect from a day one registrar? Because I think that's hugely variable.
Yeah.
Hugely variable depending on where you work, who you work for, any number of factors. And I think until you've got a good answer to that question, it's very difficult to find a set of metrics that really measure for it.
Yeah.
I don't envy the people who have to design the training programs, that's for sure.
So if you didn't get your ST3 number, what would you have done if anyone was to be listening to this podcast and unfortunately didn't get the number? Any advice and tips? Stefan, do you want to go?
Yeah, I was silent through that. I wasn't able to apply for core training when I came over. In terms of that, you have to want to do your specialty. Yeah, you have to commit everything to it. I can only imagine for core training, when you look at the application for that ST3, it can be very daunting. Yeah, it takes a very committed individual to put heart and soul into filling out each and every aspect of that assessment itself. In terms of if you don't get a number, like some of my colleagues didn't get a number, it's very to pick it up again and see where you can improve. It's a very frustrating process because you do all this work and you only have 3 stations. And if you mess up one, that's it. And to tell someone to wait an entire year when all your friends and colleagues are progressing, to try again when the goal bar keeps moving, for myself, it took me 4 times of applying, but I knew this was a surgical specialty I wanted to do. I had very little transferable skills, and I took on the challenge as an international medical graduate to do, to fill out that portfolio. Fortunately, I would have to accept Caesar because, as you all know, doing this process, you're not getting any younger. And there's only so much time you can put off having a family, getting married and moving on with your life. I would tell the individual, if this is something you really want, you can keep at it, but it might come a time where you might have to look at Caesar and go, it's not the path I've chosen, but other people have gotten through, and you just have to go and do it. It's challenging. It's very difficult. And I think more and more, the system wants junior doctors to choose very early which specialty they want to go into, just like the American system, where you just finish medical school and you go into either medicine, surgery, or wherever you were able to get into. It's not a fair system, but it's a system we have. Yeah. But there's light at the end of the tunnel. It seems as though the trainers and those that are in charge are looking at the feedback and trying to adapt the system more.
Yeah, so I think in terms of people not getting ST3 jobs and other things, I think it's very important to take a long, hard look in the mirror. You need to sit down and ask the question of, how much do I want this exactly? How much uncertainty and instability am I willing to tolerate to get this? If you're looking at going potentially round and round 2 or 3 times, how much more happiness will being in this specialty bring me, and are there other things I could be happy doing? And I say this as someone who probably could have been happy doing probably most things as a medical specialty. To be honest, I tend to get very interested in whatever I'm doing, as opposed to someone who's been pretty diehard committed from the start. But I think it's good to have asked yourself those questions early and have a cap on it when you apply for ST3 the first time. I've thought through it and go, am I that person who wants to, bang my head against this wall until I break through? Am I someone this is my preference, I'm going to give it one really good go, and if it doesn't work, it doesn't work. And just in advance having that plan to think, when am I going to stop with this if it doesn't work the way I want it to? Because there are plenty of extremely good, extremely capable people who end up in a situation where they haven't got what they wanted, and then find themselves having this discussion for the first time, having failed to get their job on the second or third time, and then having a real struggle as a consequence.
That's useful. Thank you. Talisa, anything?
I'd just say on a very simplistic level as well, if somebody doesn't get their ST3 number at all, or in the location that they're after first time round, don't worry. I know so many colleagues who have applied twice, who've applied 3 times, applied 4 times. They've maxed out, and people get there if they're persistent. I think obviously there's an element of being realistic, and I think both of you have also alluded to that already. But on the whole, I think after 1 year of trying to apply, particularly if you've only just missed it, when you get the feedback, it gives you a breakdown of each station and how you've scored on each area points wise, and there's some written feedback as well. There's so much to take away to reapply the following year. And I'd say it's almost less common to get in first time round than it is to get in subsequent entry years. So I really wouldn't worry for people listening to this who haven't managed to get in first time round.
As you might know, run-through training for ENT started 3 years ago, ran for 3 years, and then stopped this year. There have been speculations about reason why this has been stopped due to rota gaps and creating 2-tier trainees. What are your views on run-through training and any experience you heard from other people? And essentially, are you against it or for it?
So I'm not hugely pro run-through training for a couple of reasons, probably partly selfish ones, in that I don't think run-through training would have suited me particularly well at all, as someone who decided relatively late on and went around the houses a little bit in terms of gaining experience in lots of different places. I agree about the dual nature of trainees. I think it's very difficult as a supervisor, even if you're pretty self-aware, not to have a certain amount of disparity in the way you treat trainees from different backgrounds, and it's something you have to be really careful with. And I think if you have run-through and core trainees, particularly in the same unit, I think that does set a very difficult precedent for sort of 2 reasons. I think there are a couple of ways you can look at it. One person may sit there and say, I have projects that I'd like to get the trainees involved with. Maybe I should give preference to the core trainee in that they're going to have national selection coming up, and therefore the projects are more important to them right now. Or maybe I should give preference to the person who is dead set on ENT as a career, and they're definitively going to be with us until they're a consultant, provided they tick all of their boxes. I think it's hard enough coming from the perspective as a senior trainee looking after SHOs. I think one of the most difficult things you deal with as a trainee is the junior tier of the rota, and how do you distribute experience and how do you distribute work among people from different backgrounds who are doing different jobs, particularly if you work in a unit where, for example, you have 3 different types of people, all of whom might be interested in doing ENT as a career, all who are vying for the same work, but all of whom have different expectations placed upon them. So say, for example, you have an education fellow, you have an anatomy demonstrator, you have a core trainee, you have a core trainee who's plastics inclined. You then have a trust grade who's been very committed to your department, who is perhaps an international medical graduate, who is interested in applying, but is not in the training post. And I think it's hard enough making sure that those people get what they want without making someone feel like they're being unfairly penalized or not singling someone out, without adding in an additional tier between the trainees that you then have to take into consideration as well.
Yep, fair enough. Talisa?
I used to be quite pro the idea. I guess being a bit biased, I decided on ENT pretty early. And if I had been offered a post, I would have taken the run-through route for sure. I think we've already touched on this in the podcast thus far, but the way that core training works, in terms of job allocations, it shouldn't discriminate between run-throughs and those on an ENT-themed training program. So clinically, people should be getting the same exposure during their core training. Being known as a run-through core trainee, so ST1, ST2, as opposed to CT1, CT2, shouldn't, in theory, change the skill that you're coming out at the end of the program with. The other thing that I've already mentioned, the process of preparing for ST3 and national selection, and I would really advocate going through the material for all people who are starting life as a registrar, because even though those on a run-through program will naturally transition into their new role, in terms of their responsibilities, going from the SHO to the registrar rota is a big change. And I think the best way of preparing for that, other than perhaps having the opportunity on a day-to-day basis to step up on a sort of informal basis, is to actually go through the scenarios that you need to think about during the interview preparation process. So from that perspective, again, I'm pretty pro the option to have to reapply at ST3. I think the third thing to say is that people change their minds, and I don't think there are quite the numbers that have come through the programme yet to show how many people are having a change of heart, either geographically and moving across the country into other deaneries, or by specialty altogether. Maybe ENT is not for them and they're interested in other surgical specialties, or perhaps they're not interested in surgery at all. And I think the core training programme offers that little bit more flexibility to divert away from what was initially thought to be the proposed plan for the next however many years.
Yeah. Sam?
Yeah, I just wanted to follow on from that. I think the other thing with core training, as you said, there's this question of people changing their mind. And I think if you put someone in a run-through post, there's always going to be a tendency to choose the safest option, even if it's not necessarily the thing you find that you definitively want to do. It's very hard to leave a training program when you've got that job guaranteed and insured in. And I think the other thing that's nice about core training is that it does give people potentially a natural break to explore other things, perhaps alongside their clinical work that they're interested in. I think that there's a very prevalent feeling among most junior trainees, particularly, that jobs doing other things like being an education fellow or doing a research fellow or whatever other job that kind of fits in that's not really within the core training or within the higher surgical training program are there as a vehicle to get people ST3 jobs. And why would you want to do one of those unless you're doing it to gun for points? But there are people out there who, and medical education is a really good example here, who really like medical education and think, you know what, I would really like to have a dedicated year where I can pursue that interest further. And people often find their sort of extracurricular interest a little bit further on and find out what it is that they really want to do. And it's nice to be able to potentially have that option of saying, you know what, I've got a year now where there's a natural break where I can choose to broaden my horizons a little bit, or to find my niche outside of the clinical work that I'm going to take on into my higher surgical training. Because ultimately, at the end of the day, once we get to the end, all of us are going to be educators, managers, researchers. We're going to be something above and beyond what we are as clinicians. And I think it's a nice opportunity to be able to find that.
In my opinion, I don't think there should be two entries. So it's either you're going to have core training or ST1. As Sam was saying, core training allows doctors to look into different specialties, and it's mostly for those doctors who haven't really decided on which specialty they want to go on. So it gives them that leeway. But the thing when run-through started was that they didn't create new jobs. They just took jobs from ST3 numbers and basically used those as ST1. So it basically not cut in half, but it took jobs for potential candidates that were trying to get into ST3. So it's either you make one pathway and just stick with that. Again, I think it's quite hard to ask a foundation doctor to decide what they want to do for the next 7 years. But in terms of ST1, it helps those in terms of giving them some stability, knowing that they're going to be a region and they don't have to move. So that would be the advantages there. But I definitely just think there should be one pathway to entry.
Yeah, it's one of those things. I think the SAC chair was saying that it's probably not going to come back anytime soon because other specialties having a lot of issues with it, not ENT specifically. Ravina?
I just wanted to touch on something that I wanted to talk about earlier, actually, which was there have been a lot of changes after COVID, and a lot of feedback from trainees has been taken on regarding burnout. And a consequence of that is that now anyone can go less than full time without having to necessarily give a reason, which the trainers alluded to earlier in the podcast. And they said, actually, it makes workforce planning quite difficult. However, of course, from a trainee perspective, there's a completely different angle to it as well. And the trainers were acknowledging the pros and the cons of it. So it'd be quite interesting to get your guys' perspectives on the emotional effects on trainees during COVID. Did you feel supported and mentored during that time? And are initiatives like allowing the flexibility for anyone really to go less than full time a good thing?
Just to clarify, that's less than full time Cat 3, which we started again. Yeah.
So I would say, from the COVID perspective, speaking personally, if we're going to say that now is post COVID, which is obviously a question that's open for debate, I would say that my personal experience has been that I have struggled a lot more post-COVID than I did during COVID, because I think so many things moved around. There's been so much workforce shift and so much pressure as a consequence of us developed on service delivery inevitably has impacted certainly in my experience, has taken any of the flexibility that I had in the job to seek out my own training and to seek out the stuff that was most relevant for my own continuing professional development and goals, particularly as a senior trainee where my needs are obviously significantly more targeted than they are for someone who's perhaps just coming into the training program. And that's something I've really struggled with. And I found it very difficult often to persuade units that are in a situation where they are faced with a huge amount of backlog of work, particularly when I'm in a situation whereby there is a lot of work that I can do semi-independently or completely independently, not to feel pressurized into delivering large amounts of service at the expense of my own training. And I don't think that's a problem that's going to get better, certainly within the next half decade, if within the next 10 years. And I think that's something we need to think about really hard.
I would agree. I think it's always been difficult to balance service and training. And I think in this post-COVID era, in inverted commas, I think it's actually much harder, you're so right, to gain those extra training opportunities because there is just so many patients who need to be seen in clinic, for example, or in more junior than us, the SHOs even, there's so much more pressure on the service. And specifically, with regards to the new changes with less than full time, any thoughts?
I can jump in there. I don't think there's any right or wrong answer to this topic. And I also don't think it's a conversation that's exclusive to surgery or even medicine. I think a lot of industries are having this discussion at the moment. and are recognising how challenging it is to accommodate for less than full-time people as an overall workforce for various reasons, either by choice for just sort of general lifestyle reasons, for burnout, for family reasons, for personal health reasons. So I think it's quite important to point that out, because often as doctors we can become a bit woe is me and it's only happening to us. But actually this discussion is happening on an enormous front at the moment. So I think it would be interesting to maybe draw some inspiration from other industries as well in terms of what the NHS can take on board to tackle the issue.
We put 40% of our lives into this job, and or maybe even half, and you have to put so much things on the back burner, and then you might just want to have some time to have a family or raise kids, and you should be able to do that. But I think the problem is when you're looking to fill rota gaps is that you have doctors that want to work, but you're thinking in the back of your mind, you can't go over this much ENT, or you can't spend this much time in surgery. And that's why it gets quite difficult, I feel, for doctors to fill these spots, because they come in to do service providing, and then you can still learn in that job. But then when you're thinking that I can only do this job for 3 months, then I have to drop out and do something else, or I'll go over this time limit, it becomes quite challenging to fill those gaps.
It's really interesting. I had a colleague going back some way who actually chose the Caesar route, having been offered an ST3 post on their third time round. They'd gone through 3-4 years after core training, applied, eventually got their ST3 job and went, you know what? I've put down roots here. I bought a house. I have 2 young children. I have a wife who's set up as a GP. I'm not sure what I get from being an ST3 now is really worth the sacrifice anymore. But at least I can say I could have done it, and I can rest easy at night time.
Yeah. I think that's a very important perspective to get, that trainees are not just thinking about training all the time. There are things in life and next stage of life that people need to plan and things about. Yeah.
So I think just to perhaps bring it to a close, I think we wanted to ask, just like we asked the trainers, what is the future of ENT surgical training? Where do you see it going? How can we make it better?
So I think there's certainly a way to go with training in general, and I think everyone acknowledges that. I would hope there will be a move more towards using training as a way to support people rather than as a stick to beat them around the head with, which is something it is used as in some of the worst case scenarios. I think it's really important that we make sure that people's time is used well and that it's valuable. We should really move towards cutting some of the redundant bits of assessment and paperwork and other things from training, and really focus on collecting exactly that kind of data that we talked about, that kind of what makes a good day one registrar, what do people really expect from a consultant, how confident and capable do trainees feel they are at the end of the training program. And I think we should be using that to generate good metrics and a good understanding of, well, essentially assessing people based on what's important and what's been shown to be important and what actually works. And also using that from the other standpoint to make sure that we then hold units accountable to say, you know what, right, this is the stuff that is important and this is the stuff that you have to give trainees. Because at the moment, depending on where you work, obviously depending on which unit in which region, you can find yourself in a situation, as I've had multiple colleagues who have, where you feel you're fighting tooth and nail to get the things that you know that you're supposed to have. And ultimately, at the end of the day, the default will tend to be, when you sit there in your ARCP meeting, that this is your fault. This is not necessarily the fault of the place that you're working. And as I say, that's not the case everywhere, but I would hope that there will be a bigger move to balance that out and to make sure that the quality of training posts, particularly at core training level, is better overseen, that things are held accountable, but held accountable by the measures that we know that are relevant, rather than things that have been variably arbitrary.
Yeah, I think the future is quite bright. I think that over the years, the system is realizing what works and what doesn't. I mean, we have ISCP, you have ERCPs, you have trainees having more power to say that in terms of their feedback and national surveys, to say which hospitals are good and which hospitals aren't. And the GMC and SAC takes a look at it, and they then refocus or redistribute their trainees to different institutions that work better. I feel, as Sam was saying, that things will become more streamlined. The useless paperwork will go out, and more focus we put on what is required for a day one registrar and a day one consultant. You can take a look at the requirements now where ISCP is going for like level 4s to being able to do this as a day one consultant, these types of changes in the requirements. So you can see that the system is slowly but surely going in the right direction.
I think from my perspective, it would be nice for the shape of training to become more individualized. I think there's a lot of feeling amongst current trainees that we're part of this mass system where we're just a number amongst very many. And although that will potentially fulfill the needs of service provision at the end of the day when we're being churned out the other end as consultants, I think there's a lot to be said for customizing training a little bit more to allow for people's strength to really come through rather than, again, focusing on the constant tick boxing exercises that we're assessed by at the moment. I don't have a solution for that, but I think as an overall principle, it would be something that's very nice to gear training more towards, if at all possible.
Yeah, I'd like to agree with that. I think the thing I would like to see in training, I would really like to see more support made available within the program for people to pursue those things that they are most interested in doing. At the moment, I think two of you guys are academic trainees, and I think the academic foundation program and the ACF program has gone a long way towards this. But I think it's important in the future that we think about how we allocate our resources to help trainees to pursue things that aren't necessarily just academia. For example, improved mentoring for management, service improvement, education. And personally, I would like to see, seeing as we've moved towards declaring a subspecialty in the final few years of training, I would like to see training move towards people declaring a subspecialty outside of their job and there being a structured mentoring scheme set up for people to pursue that, whether that's education, whether that's management, whether that's service improvement, whether that's academia, but having a point of call at deanery level, at consultant level, either within or outside of your unit, and some budgetary allocations and requirements for people to pursue those things that they are most interested in doing.
Yep. On this point regarding support, thank you, Sam and Stefan, for mentioning this. Actually, WENS as an organization do have the mentoring scheme, which you guys can all sign up to become a mentor or a mentee. So I think this is a wrap of our podcast today. Thank you so much, three of our speakers today for your time.
Yes, it's been so great to have all of you on the podcast and taking out your time. So thank you so much. So Tanya, what do you think you could have gained from knowing all of this information before you applied? Because I know you recently have applied and gone through the process to become a core surgical trainee. And we've learned so much from recording these podcast episodes with our speakers. What have you gained?
So for me, I do believe that knowledge is power. So one of the things that I think I would have gained from listening to this podcast as a listener would be knowing what the path in front of me would roughly look like in terms of core surgical training and then higher surgical training. So that's the first point. The second point, I guess, it all comes down to having support and mentors in both the trainees and the trainers part of the podcast. This has been a recurring theme. So I think it's very important, for me to learn that it's important to identify a mentor earlier on. What about you, Ravina?
I think it was just very nice to hear everyone being so candid about their experiences, and actually quite comforting to know that the same worries and anxieties we have as trainees, our consultants probably had a few years before us, and actually we're all in the same boat and there was a lot of support out there for us. And that was really nice and reassuring to hear.
Thank you, Ravina. It's been a really great experience. Hopefully we'll be able to do an update on perspectives regarding surgical training in the next few years when we ourselves progress in our training and as the changes are coming with surgical training in very near future.
Yes, I hope we get the opportunity to do that. So thank you to all of our speakers, and we'd like to say a special thank you to Heather Pownell, who produces this podcast, and finally to you, our listeners, for tuning in and listening to both parts of our podcast. Please feel free to leave us any feedback either via Twitter. Our Twitter handle is @WentesUK, or via our email address. And please do continue to follow us on social media to join our conversation. Thank you so much.